Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. More and more research is showing a connection between Epstein-Barr virus and multiple sclerosis. For help understanding the relationship, I turn to Dr. Corey McGraw, an associate professor of neurology and director of the Center for Multiple Sclerosis Comprehensive Care at Upstate. Welcome back to The Informed Patient, Dr. McGraw.
Well, thank you so much for having me back. I appreciate it.
Before we get into the research, I'd like to ask you, what is Epstein-Barr virus? Is it the same thing as mono?
This is an area that has become very interesting recently. So Epstein-Barr virus is a very common virus. It falls into the category of viruses called herpes viruses, common viruses that infect people. I think we know some of them, the herpes simplex virus that causes cold sores, but it also includes viruses including the chickenpox virus, varicella zoster virus, another virus called cytomegalovirus or CMV, which we're going to talk about later. So it falls into that category of viruses that infect humans. Now, mononucleosis, on the other hand, is the clinical symptom of having an EBV infection. So most cases of infectious mononucleosis are due to EBV, but about like 5% are due to that other virus I mentioned, CMV.
How common are these viruses? How many people get them?
Almost everybody gets these. We're going to speak later, but about 95% of people are going to be EBV or Epstein-Barr virus positive in their lifetimes. Most people will have the varicella virus, although with vaccinations against chickenpox, many young people are not infected with varicella. And most people will have a herpes simplex virus, either HSV1 that causes cold sores or HSV2 that can cause lesions in the private areas.
Where does Epstein-Barr virus come from and how does it spread?
These types of viruses have been with us probably all through our history. EBV in particular is shared through saliva. We might have heard of mono as being the kissing disease. This is where this comes from. So we can share it both with sharing saliva, but also just on any infected surfaces, including glasses, shared food. Through that, it will infect our mouths and our throat. And it spreads by infecting those cells and then destroying them. As they destroy them, it releases more virus, and that's how it gets back into the saliva to be shared. But what's interesting about Epstein-Barr virus and actually all of the herpes viruses is that they can also set up shop long-term in our immune system. So part of our immune system called B cells become infected, and then it's very difficult to clear the virus from our bodies, and we're left with this chronic EBV infection.
What are the symptoms that EBV causes?
So the most common symptoms for infectious mononucleosis, and many people have probably experienced this, would be sore throat, swollen lymph nodes, especially swollen lymph nodes actually in the back of the neck, a classic finding for mononucleosis, and fever. People can have profound fatigue, bad inflammation of the tonsils, body aches, headaches, the kinds of things you'd expect from an acute infection. It can also, though, affect other organs, including the spleen and the liver, more rarely.
Is it diagnosed with a blood test?
It is. So in the right clinical setting, so at the right age, so young people, usually between the ages of 15 and 24 are the peak of EBV infections, or that is to say mononucleosis. In the right clinical setting, there are blood tests. One is called the monospot test, which has been used for many years. It is accurate when patients are in the right age group and have the right symptoms, but it can be negative in the first week of infection. And so there are more specific blood tests that measure what we call antibodies against EBV. And these are important because we're going to talk later about using these antibodies to measure EBV infection in folks who ultimately got diagnosed with MS. Anyone who comes in with a question of mononucleosis is also going to get a complete blood count because people's white blood cells can be quite high when they have mono, and liver function tests to make sure that it's not affecting the liver.
What is the course of illness usually like?
Most people's symptoms peak at about 1 week. It can last 1 to 4 weeks and start improving at that time. Although a good amount of people may be left with a very long-standing fatigue or chronic fatigue that can take months to get better.
And then if you end up having chronic EBV, is that after you've had the acute infection, or could you potentially just have a chronic case that is there, but you don't have symptoms from?
Well, that's exactly right. What's interesting about these viruses in general is that you may not have the acute infectious symptoms when you become infected. So, about 1 to 3% per year of young people will um, have infectious mononucleosis, the symptoms of mono. But actually, the vast majority of people don't ever have mononucleosis. And yet, by late adulthood, almost everybody has been infected. So people may not experience an acute infection, but almost everyone will eventually be infected with EBV. One interesting study looked at college freshmen. I sort of loved this study because, it looked at college freshmen who, might be sharing saliva. And about like 30 to 75% of those came in not positive for EBV, again, measuring those antibodies. And then about 10 to 20% became infected every year. So it's a good time to get mono.
This is Upstate's The Informed Patient Podcast. I'm your host, Amber Smith. I'm talking with Upstate Neurologist Corey McGraw. Now, what is multiple sclerosis?
Multiple sclerosis is one of the most common neurological diseases. It is an inflammatory or autoimmune disease. So this is a disease that affects the central nervous system. The central nervous system is the optic nerves, the brain, and the spinal cords. It oftentimes affects young people, and it is a disease in which people develop what we call lesions, or you can think of them as spots of inflammation within those areas of the central nervous system. Those spots or lesions cause neurological symptoms. So the symptoms depend on where the spots develop, but a classic presentation would be the development of loss of vision in one eye, which is called optic neuritis. A very common first presenting symptom of MS or multiple sclerosis. Lesions within the brain can cause any type of symptoms: numbness, weakness, dizziness, double vision. And then spots on the spinal cord can also cause weakness, numbness, trouble with bladder or bowel function, and problems with walking. MS is what we call a demyelinating disease. It affects the insulation on the wires of the nerves of our central nervous system. So each of our nerve cells have long projections called axons, and those are like the wires. And each of them are insulated, something called myelin. And for reasons we don't really understand, the immune system learns or mislearns to attack this myelin. And so this category of diseases are called demyelinating diseases. So you can think of these spots or lesions within the brain as being areas where the wires have lost their insulation and now the bare wires are touching each other. So you can imagine that causes electrical shorts and other types of symptoms that can manifest in the way that we described.
So do people who have a suspicion of having MS, would their primary care provider send them to the Center for MS Comprehensive Care to get a diagnosis?
Yeah, so in our region in upstate New York, MS is very common. So about 1 in 265 people have MS in upstate New York. And that means many, many people have MS who have not yet been diagnosed. I do encourage people to speak with their primary care providers if they're concerned that they might be having MS. And then their providers would refer them on to us. Absolutely.
How do you go about diagnosing this?
So the diagnosis of MS is a challenge because it's primarily clinical. So someone may experience, a young person, maybe they're in their teenage years, experiences numbness in a leg for 2 weeks. That's a pretty non-specific symptom. And many people are going to experience symptoms such as this that aren't related to having MS. On the other hand, there are symptoms that are much more specific. I mentioned that inflammation in the optic nerve called optic neuritis. About 25% of all people who have MS, their first symptom or their first attack is optic neuritis. So a much more specific symptom. So it depends a little bit on what the symptoms are. But things to be concerned about would be new neurological symptoms that someone's not experienced before, that they would have no other reason to be experiencing, symptoms that evolve over a few days to a few weeks and then tend to get better on their own. We call those attacks, exacerbations, or relapses. They all mean the same thing. And the idea is that at least early in the disease state, people are experiencing these symptoms. But I would encourage anyone to speak with their doctor if they're concerned. Underdiagnosis is a major problem with MS. We're going to talk a little bit more in the future about this, but we have preventative treatments that reduce disability in MS. So it's very important to be diagnosed early.
I was going to ask how it typically is treated and what the course of the illness is usually like.
Yeah, absolutely. Early in the disease state, again, tends to be young people. There's about a 3-to-1 predominance of women over men early in the disease. So early people have these attacks or exacerbations or relapses, and those symptoms mostly get better. And so we can be sort of lulled into the idea that, oh, well, I only have symptoms when I have them and they go away. Under the hood, in that central nervous system, though, the damage is accruing over time. So people are developing these lesions, these spots, and over time, they start to build up. And as you might imagine, the more and more you damage the nervous system, the more likely you are to not recover from your next attack. Then as people get older, and especially as they've had uncontrolled disease for many years or many decades, they can have what we call progressive symptoms. So this is where rather than having acute symptoms that come and get better over weeks, they get insidiously worse over time, and it's much harder to treat. Early in the disease course, we have highly effective medicines. We call them disease-modifying therapies. And we now have over 20 medications, highly effective, safe, and tolerable. The key is getting the diagnosis early and starting those medicines early.
Let's talk about what causes MS. Is there evidence that infection with the Epstein-Barr virus can cause MS?
Yeah, so this is what's been extremely interesting in the last few years. A really seminal paper in 2022, a group led by Dr. Bjornvik published an analysis of U.S. military recruits and looked at their risks for MS and their infection with EBV. So as you might imagine, our military recruits are quite closely evaluated when they enroll in the military, including blood tests, extensive medical evaluations, and that blood is saved. So they looked at over 2 million U.S. military recruits and then over time looked to see who developed MS. And in that group, about 955 people developed MS. They were then able to go back and look at their Epstein-Barr virus antibodies. And what they found was that for people who had the Epstein-Barr antibody in their blood at the time of their recruitment, their risk of developing MS was about 32 times higher. So this was shocking. To see a risk like that really suggests that EBV is an important part of developing MS.
And you've already told us about how 95% of us have the Epstein-Barr virus or had it. So does that mean we're all susceptible to developing MS?
Well, I think that's right. About 95% of people by late life will be EBV positive. But, we don't think that EBV is the only cause of MS. So we think that it may be necessary to develop MS, but not sufficient. So not the only thing leading to the development of MS. Interestingly, in that study, one person developed MS who never was EBV positive. So that just goes to show you that it's not an all or none. But the vast majority of people, it seems that EBV is necessary for developing MS. Incidentally, they looked at those other herpes viruses in that study. I mentioned that CMV, which about something like 5% of the time, 10% of the time causes infectious mononucleosis. And there was no association between being CMV positive and developing MS. So it really suggests that EBV in particular is necessary for developing MS.
So that was one study. Is there other research that shows a connection?
Yeah, absolutely. Since that time, there's been a number of other studies looking at this. As you might imagine, that one study may not be representative of the general public, right? I just mentioned that there's about a 3-to-1 ratio of MS in women compared to men. in the United States. As you might imagine, these military recruits don't represent the American population overall. First of all, they were male, vastly more male than female. They were young. And of course, they had to meet very specific physical requirements, right, to enroll into the military. So while this is very interesting, it doesn't necessarily mean that it applies to everyone, and particularly in the US. This study and studies like it have been what are called observational, right? So they can't show a causal link, meaning that the one thing causes the other. They can only show that there's a correlation between the two, namely being EBV positive and developing MS.
You're listening to Upstate's The Informed Patient podcast. This is your host, Amber Smith, with my guest, Dr. Corey McGraw, a neurologist at Upstate who directs the Center for MS Comprehensive Care. When you're looking at a patient who's trying to determine whether they have MS, do you look at whether they had EBV positive mono in their history? Is that part of it?
That's a great question. So there's a debate right now within the community as far as whether that's useful or not. Because almost everybody is positive for EBV who walks through my door, I don't think it's a very useful test right now. There are a few cases in which I might do that. For instance, if there's someone who I wasn't sure if they had MS or not, so they have some symptoms suggestive, maybe their MRIs, their imaging of the central nervous system is equivocal. It might be helpful to measure an EBV antibody because those people who are negative would be much less likely to actually have MS. There are many studies ongoing right now about looking at not just whether someone is positive or negative for these EBV antibodies, but the amount of positive they are, so what we call a titer, and also looking at different types of antibodies that are associated with EBV to find out if the amount or the type of antibody is more predictive.
So it sounds like someone who had mono should not panic at this point about getting MS as they get older.
That's exactly right. That's exactly right. The risk of developing MS for those who had infectious mononucleosis was about double. But that's a pretty small amount. I mean, double sounds like a lot, right? But in one study, the risk of developing MS went from about 12 in 100,000 to 22 in 100,000 if somebody had a history of infectious mononucleosis. So we're talking small numbers there, right? 12 in 100,000 is a very small amount. So the absolute risk of developing MS just because you had mononucleosis is still very low.
And if I understood you correctly, there's other factors, and we don't know what they all are, that play into whether you're going to get MS.
Yeah, that's right. So actually, much more importantly, seems to be a few interesting things that are applied to the people of upstate New York. So first of all, growing up in a northern latitude is strongly associated with the development of MS, aka upstate New York. Upstate New York has one of the highest rates of MS in the country. And in fact, by one measure, Syracuse by municipality had the highest rate in the country. So part of that has to do with growing up in a northern latitude. What is that all about? It probably is due to a number of things. We think it probably has to do with the seasonal viral exposure. So when you live in the temperate climate, we're exposed to these seasonal viruses that are constantly changing and adapting so that they can continue to infect. And so we get pulsed with these very ingenious viruses every year. Very different if you live around the equator. There's a wet and there's a dry season, but there isn't this pulse of seasonal viruses that occur. So we think that's a piece of it. Maybe it's not surprising to our listeners now to hear that other viruses might be involved since we've been talking about EBV. Vitamin D exposure, so very important. So the risk of developing MS with low vitamin D levels is much, much higher. And that may be a part of living in the northern latitudes, right? Is that we get much less sun exposure. Childhood obesity is a risk factor for developing MS. Smoking is a risk factor for developing MS. So these are all factors that play an important role in the development.
Are there any efforts underway to come up with a way to prevent MS across the board?
Mm-hmm. Yes, absolutely. So, this data on the EBV virus really opens some interesting doors, right? So if EBV is largely necessary for developing MS, then, the prevention of EBV infection might translate into real reductions in MS. So there are a couple of different ways of looking at it, and we don't yet know the answer to these questions. But the main question would be, is it that you need the EBV infection initially, and that's what sets you up for the risk of MS? Or is it an initial EBV infection and then this ongoing chronic infection? I should take a step back just to say that I had mentioned that EBV invades and lives permanently in our bodies. So it invades into our immune system itself, into these cells called B cells. And B cells are very long-lived types of immune cells. It lives inside these cells and actually reduces itself down to almost nothing. And so it can live silently in these cells and then occasionally reactivate and spread then from B cell to B cell. And so what that means is that perhaps the ongoing infection within our B cells is a piece of the puzzle of driving MS disease activity. We know B cells are an important part of MS disease. Some of our newest medications, our newest disease-modifying therapies actually reduce the number of B cells, and they're highly effective at reducing MS and exacerbations. So there's a connection there. So, for prevention, do we just prevent the infection to begin with? And that's our only mechanism to treat MS related to EBV? Or does treating the ongoing infection itself translate to reductions in disease activity?
Good questions. Well, this has been very interesting. I appreciate you making time for this interview, Dr. McGraw.
Well, absolutely. Thank you so much. I appreciate this. So, I would just encourage anyone who is concerned about their symptoms to reach out to their primary care doctor, ask for a referral to the Comprehensive MS Center. Our number is 315-464-4243. So please send those in and we'd be happy to see you.
My guest has been Dr. Corey McGraw, an associate professor of neurology at Upstate and the director of the Center for Multiple Sclerosis Comprehensive Care at Upstate. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.